Good afternoon, everybody. I'm Aaron Battle. I'm the Chief Operating Officer for the New York State Chronic Kidney Disease Champions. The New York State Chronic Kidney Disease Champions is a patient organization whose mission is to provide information, resources, and support the CKD community. The Champions are committed to improving the quality of life of renal replacement therapy consumers by providing education, encouragement, and empowerment. I would also like to introduce to you today our executive board members, who are Don Edwards, who is our CEO, and Stephanie Dixon, the CFO, Shelba Jones, our associate director, and also Luis Matos, who unfortunately can't be with us today. We would like to welcome you to our World Kidney Day live broadcast. The 2018 World Kidney Day theme is Kidney Disease and Women's Health: Include, Value, Empower. We are here today to educate you regarding CKD. CKD is a worldwide public problem. It affects approximately 195 million women worldwide, and it's the 8th leading cause of death in women, with close to 600,000 deaths each year. I'd also like to let you know, too, that today is International Women's Day. Stephanie Dixon.
Thank you, Aaron. Good afternoon. The risk of developing kidney disease is at least as high in women as in men, and it may be even higher in women. According to some studies, chronic kidney disease is more likely to develop in women compared with men. But the number of women on dialysis is lower. There are 3 major reasons recognized. First, the progression is slower in women. Secondly, the psycho-socioeconomic barriers, such as lower disease awareness, leads to late or no start. And uneven access to care is a major issue in countries with no universal health care or access to health care. Transplantation is also unequally spread, mostly due to social, cultural, and psychological aspects, even in some countries where transplantation and equitable treatment is available. Women tend to donate kidneys more, and they are less likely to receive a kidney. For some other causes that affect women, we encourage you to educate yourselves about women's kidney health. I now turn the program over to Dawn Edwards.
Thank you, Stephanie and Aaron. I am here this afternoon with Dr. Mariana Markell. Dr. Markell is a nephrologist here at SUNY Downstate Medical Center, and she specializes in women's health. Good afternoon, Dr. Markell. Thank you for being with us.
And good afternoon, Dawn. Thank you for inviting me on this wonderful World Kidney Day and Women's Health Day.
Well, I'm just going to jump right in with the questions. And the first question that I have for you is, how would someone know that they have kidney disease?
This is a really, really important question, because there actually is no way to know that you have early kidney disease without having a blood and urine or urine test. In fact, most kidney diseases are completely without symptoms until very, very late in the game. And so it's very important, if you have a history of high blood pressure, diabetes, or a family history of kidney disease, to make sure that your doctor has done a blood test that includes the creatinine value, which gives us what we call an estimated GFR, as well as urine for albumin-creatinine ratio, which can sometimes tell us very early that there's a risk of kidney disease.
That's very important information. Well, why do some people that have kidney disease still urinate?
This is another really important question, because to understand that, you have to understand what the kidney does. And kidneys do lots and lots of things. They get rid of waste products, they make chemicals that are very important in the body, and they also get rid of fluid. And in fact, the normal person will filter hundreds and hundreds of liters of fluid a day, but they'll reabsorb it back into the body. Okay. So when your filtration rate, which is a measure of kidney function, gets very low, when you have kidney failure, it could be as low as 10 milliliters a minute. Mm-hmm. If you don't reabsorb any of that fluid, you will still make urine, but the urine has no waste products in it, and you need dialysis even though you're making urine, or you need a transplant.
I understand. So it is easy to get all of that confused.
Absolutely. It's very commonly confused that, you know, because you're making urine, it's what we call good urine. But in fact, it doesn't have the waste products in it, and they build up in the blood.
I see. Well, I want to ask you a question about women's health. Is it okay to get pregnant if you have chronic kidney disease?
Now, that's a little bit of a complicated question, and of course, you know, if you're considering pregnancy with chronic kidney disease, you definitely need to speak to your doctors about it. But in fact, it's not absolutely contraindicated. Some kidney diseases will get worse, and others will probably stay the same. The one thing I will say is that any pregnancy will be very complicated and needs to be managed by a high-risk obstetrician, because the high blood pressure, and if you have protein in your urine, that could also, both of them can get worse. So it's not an absolute no-no, but it's very important to work with your nephrologist, your internist, and your obstetrician if that's what you want to do.
I understand. What about if you're on dialysis?
On dialysis, it becomes even more complicated. Many people think they can't get pregnant when they're on dialysis, but in fact, especially since the advent of erythropoietin, people do get pregnant on dialysis, and it requires a very, very careful coordination. You have to have dialysis pretty much every day if you're pregnant, and the fluid has to be managed very carefully. So it's quite a complicated situation. In general, we don't recommend it, but if you find yourself pregnant, it's not a situation where you absolutely can't carry the baby, at least to the point where it could be born alive.
Oh, I understand. That sounds like a really, really difficult situation.
It is a very difficult situation,
Yeah.
you know, and as opposed to kidney transplantation, when very often we have women have perfectly fine pregnancies. Again, it's a little bit complicated,
Right.
but if you have relatively good kidney function and no other diseases that might endanger an unborn baby, then we usually do say that it's okay to get pregnant with a kidney transplant.
Well, that's good news. Why do periods sometimes stop with CKD?
Now that's an interesting question as well. You know, if you are on dialysis, you may have noticed that your periods have stopped. There are very complicated hormones in a part of the brain called the hypothalamus,
Yes.
and they are very carefully regulated. And when you get chronic kidney disease, especially end-stage kidney disease, those hormones become out of control, kind of. And so you no longer make the other hormones that are necessary to have periods. You may have a period once a year, you may have a period every couple of months, but when you do have those periods, you can potentially get pregnant. So just because you don't have your period, it doesn't mean, if you're on dialysis, that you can happily go off and assume that you won't get pregnant. And that's a very important thing to realize.
Yes, it sure is.
And in fact, with a kidney transplant, with a well-functioning kidney transplant, usually periods will return in somebody who isn't in menopause within about 6 months to a year after the transplant.
Okay.
But be aware that you can get pregnant even a couple of months after the transplant, so it's very important to use contraception.
Oh my goodness. Well, what about those periods that just run on and on and on?
That's another problem that has to do with this unregulation of the hormones, and that's something that sometimes you need to talk to your obstetrician about because it can contribute to anemia. There are injections and there are other hormones that can be given to correct that. It shouldn't just be allowed to keep going because, again, you know, it can worsen the anemia of chronic kidney disease.
Yes, I understand. Well, we see a doctor every treatment at dialysis. Does that mean that we still need to go to see the gynecologist? And what about mammograms?
Absolutely. You know, I think one of the things that frustrates me about the care of women with chronic kidney disease is that I've noticed that sometimes when they start dialysis, they do what I would call lose their gender. And the doctors, sometimes because they haven't necessarily been educated to it, they forget that they're dealing with someone who still has women's health issues.
Yes.
So it's very important to still see your gynecologist, still get your pap smears, still get your mammograms and any of the other recommendations for women's health, even if you're on dialysis and don't get your period.
That's very important information. Let's make sure that we make note of that, ladies. So, once we get a transplant, Dr. Markell, we're cured. And can we still get pregnant then?
Well, as I said, you not only can get pregnant, but you can actually get pregnant very quickly, even before you see your periods return.
Right.
So we always recommend that somebody in their childbearing years who gets a transplant use contraception. I mean, we recommend it at dialysis as well, but especially for somebody who's just had a transplant. Although it's okay to get pregnant when you've had a transplant for a while, you know, we used to say 2 years, and now we've shortened that time to a year or less.
Yes.
But in the first few months, it's not a good idea. You don't want to find yourself pregnant, you know, 2 months after you've had a kidney transplant.
Yeah, I can understand that. That would be terribly troublesome. What about the medications, the transplant medications? And a lot of people say that they're toxic. Will those medications harm the baby?
That's a really important question. There is one medication that absolutely should not be taken if you're thinking about getting pregnant, and that is mycophenolate mofetil, which is also called Cellcept or Myfortic, and it's used also to treat some kinds of chronic kidney disease. It absolutely should not be taken if you are considering getting pregnant. The other drugs, prednisone and things like tacrolimus or cyclosporin, have been used for a very long time, and there's a large pregnancy registry. It does not look like they have any obvious toxicities to the baby. And actually, children of the children who've been exposed to these drugs have been studied. And so far, it looks like they are not a problem. But absolutely, the two drugs that shouldn't be taken are any of the mycophenolate mofetils, and the other one, believe it or not, are the ACE inhibitors, like enalapril, lisinopril. Those drugs, if you're considering getting pregnant, really should be stopped.
Okay.
With the help of your doctor, of course.
I was just going to say, you definitely need to consult with your doctor, because that was a hefty list of medications. Wow, I like that. That's good news for me. Well, in the introduction, we learned that women receive less transplants than men. Could you explain to us why that is?
I wish I could. And it's an area that I'm very interested in. Women definitely donate, as you heard, much more frequently than men do. And whether this is all sociocultural or whether it has something to do with being a woman in general and being more altruistic, I don't want to offend all the men in the audience, but it's been an observation that's continued for since the beginning of transplantation. And it's something that we're going to be looking into. I don't have an answer to that, but I think it's something to be aware of. And sometimes I think women won't ask. You know, we often are the caregivers, but we're not the ones who are going to ask somebody else. And to get a living transplant, which, by the way, you don't have to be related. You know, you can have a living unrelated kidney transplant. You need to ask.
Yes.
And we call it the big ask. It's not easy.
Yes,
so,
it's definitely not easy.
So it may be more difficult for women to do that than men as well.
Sure, I understand that. Well, you know, I read a lot, and I've read and I see in lots of articles about using oils and natural herbs and supplements for beauty and as well as health. What is your take on that for women with CKD and on dialysis?
Again, this is another area that I have tremendous interest in. And the problem with herbs and supplements is that they are broken down in the body somehow. And we don't always know which ones you get rid of through the kidneys. So in general, it's very difficult to make an overall recommendation as far as herbs are concerned. But as far as oils are concerned, those do not seem to have any problem. And many other, what we call integrative therapies. For example, I think that yoga, meditation, there's no question that those are practices that should be very good for people who are on dialysis. And we even did a study here of massage. We actually did a study where we did massage during dialysis. And we found, of course, that people's blood pressure came down, and that of course, it was a wonderful thing. So we also recommend massage. So if you're interested in an integrative therapy, my preference for a patient who's on dialysis, and it's different for transplant, is to stay away from herbs per se, only because we just don't know how they're broken down and whether there will be some breakdown products that build up in the body and could be toxic. On the other hand, the essential oils are a good option, as well as some of the other therapies.
Yes. I wish I could have been part of that massage therapy during dialysis.
I wish we could get them to pay for it.
That sounds wonderful. Well, finally, Dr. Markell, in your professional opinion, how does a woman with CKD or a woman on dialysis or with a transplant, how do we stay healthiest?
I think there's no magic answer to that. I think obviously dialysis and CKD are very stressful situations, and there are many types of stress reduction programs out there. Each person is different. It may be your church in prayer, it may be learning meditation, it may be doing some sort of a practice like yoga, which can also help with, possibly with bone disease and things like that. I think eating a prudent diet, obviously staying away from junk food, and there are a lot of restrictions that you're familiar with with CKD, but it has to be individualized. And I think also having a passion for something, as you do, really helps everyone. And even as a patient with CKD or being on dialysis, you can find what it is that makes your heart sing, and that will help your life as well.
It certainly does. Well, Dr. Markell, I just want to thank you so much for your time, and we appreciate you coming to be a part of this special project, and we love you so much, and we can't wait to work with you again in the future.
And same here. Thank you guys for all that you do for kidney patients everywhere.
Thank you.
Happy World Kidney Day.
And we'll be back in just 1 minute. Okay, I guess you can get up, Dr. Markell and Dr. Cukor.
Bringing the microphone. Where is it? Where did you attach it? Got it? Put this in your pocket. Okay. Hello.
How are you today?
I'm doing all right.
Oh, thank you so much for coming.
I thought it was going to be you and a phone. I didn't realize we're doing the whole thing.
I'm just going to say I'm the return. We're back with Dr.
Okay, great.
Cukor.
Cukor.
Dr. Cukor. Yeah, this is a big deal, right?
Thank you all so much. We're back now with Dawn and Dr. Cukor.
So I'm here now with Dr. Daniel Cukor. He is, get this word, a psychonephrologist. And he is here at SUNY Downstate, and he is also a professor of psychiatry here at SUNY Downstate. So good afternoon, Dr. Cukor. It's so great to have you with us.
Good afternoon. Thank you for having me. Happy World Kidney Day. Happy Women's Health Day.
Thank you very much.
Thank you.
So, Dr. Cukor, we have so many questions. I just want to jump into the interview.
Sure.
Can you tell us a little bit about yourself and who you are and what it is that you do?
Sure. So I often don't describe myself as a psychonephrologist because I don't know that many people know what that means, but I'm a psychologist by training, and I have an interest in working with people that have problems with nephrology or kidney disease. So for the last 15 years or so, I've been working with people in different stages of CKD, earlier stages, dialysis patients, transplant patients, trying to understand what are the important issues for them, and then trying to develop or bring in treatments that we use in other parts of medicine and tailor them and try to get them to be as effective as we can for patients that have this unique challenges of living a life with renal disease.
Yes, well, we surely thank you for what it is that you do, because there certainly is a need for mental health services in nephrology. Are people with ESRD especially vulnerable to mental health problems? And why is that?
Well, I think the answer to that question is yes and no. So people in general are vulnerable to mental health problems.
Sure.
And the more stress that we have in our lives, both physically and emotionally, the more likely we are to suffer the ill effects of that stress, and that those ill effects can be expressed in a variety of different ways. It can be depression, it can be anxiety, it can be not sleeping, it can be fatigue, it can be drinking. It can, there's a lot of things that happen when we get overwhelmed. So patients with CKD, are people that have all of the other challenges of being a person, plus they have these additional challenges of being somebody dealing with chronic renal failure. And in particular, there are some really unique challenges that are associated with being, let's say, a dialysis patient. It is a really demanding treatment, and it is permanent. It is, unless you get a transplant, that is the type of treatment that you're going to need to receive, and it's really intensive and demanding. And there aren't really that many other types of treatment that are out there that are this intensive for this amount of period. So there's a lot of things that are demanding, but they're usually a relatively short amount of time. And as we all know, people, can usually behave pretty well if it's a short amount of time.
Sure.
But if you're talking about forever, so then, you kind of get back to some of the challenges. So it's, it's not like you're stepping out of your life and dealing with this for a little bit. This becomes your new life.
Sure.
So there's certainly challenges related to even just looking at the timing of the dialysis. So it's, for most folks in this country, it's 4 hours of actual treatment time 3 times a week. So it's kind of like getting an additional part-time job.
Yes, it is.
And doing that, and being able to maintain your original part-time job or your original job is very challenging.
Yes.
So plus people are not feeling well, and they're often really exhausted after dialysis. So what ends up happening is it's not really just about having the renal disease, it's the treatment for the renal disease is also really demanding and challenging. And you could imagine how going from kind of being an active, vibrant person to then finding out that you need to have renal replacement therapy, it's a really dramatic change into the person's schedule, into their lifestyle, their entire social role will often change, right? So if you've been working and taking care of yourself in the broadest sense, so now you really need help. You need help from the dialysis folks, you need help from your family, from your friends, from your network. So it really is a really dramatic change.
Yes, it
and I think because of the steepness of that change, it does make people more vulnerable to acquiring new mental health difficulties. So a lot of the people, that I see are not people that had, mental health difficulties by and large before they were on dialysis. These are people that were, I guess, like everyone, coping. They were getting by with what they had and doing okay. And then this is just, some people say this was the straw that broke the camel's back.
Icing on the cake, yes.
But it's not a straw. This is a giant rock that broke the camel's back, right? It's a really large change. It's a really large demand. So it makes a lot of sense to me that the mental health burden is really high. And we do see that things like depression are the highest for people that are on dialysis, even compared to almost all other medical diagnoses that are out there. It's one of the more challenging ones to be able to live with.
Yes. I can certainly relate to that as a person who suffers from anxiety and depression. I can relate to everything that you've said. And it certainly is challenging going from a completely independent person to almost completely dependent. So it is very, very challenging.
Yeah, and I think, anxiety and depression aren't really pathological states. They're not always signs that something is dramatically wrong with you. Sometimes, they're normal responses to really abnormal circumstances.
Right.
So the same way that we would say that somebody that's been through like a horrific experience, it's not abnormal to have a really strong response to that. So I would say, dialysis is pretty similar to that. It's a really strong demand. And to say that it's an abnormal response, I don't know that I would agree with that. I would say it's maybe an unhealthy response, but it is very understandable given how challenging it can be.
It's so great to hear a voice of empathy and understanding of the feelings of a patient who is going through something that is so traumatic. So, Dr. Cukor, are there differences in the mental health needs between women and men?
That's a good question. So there's very little data on mental health needs of dialysis patients in general. It is clearly something which is very relevant to every patient that is there, but excuse me, nephrology, is kind of just coming to its own now in terms of what I would call holistic care, or
Yes.
caring for the entire patient. So they used to be very kidney focused.
Right.
And as a result of that, there really isn't all that much data, going back for decades, looking at the mental health needs or the psychosocial needs. So we don't know all that much about the differences between men and women, but there are some things that we do know. So there are some small studies that suggest that there might be some biological differences in how women respond to stress as compared to men, and that women who are stressed, it will take less of an outside thing for them to consider themselves stressed, and then when they are stressed, they have a much stronger hormonal response, a neuroendocrine response. So they're like more stress responsive, and if you're more stress responsive, so that means that there's going to be more reaction throughout your body, and then maybe more consequence. And that consequence could be psychological, it could be physical, or some sort of combination. So there is some indication that women are more responsive to stress, particularly, that's true, I think, in general, and that's true as well in the dialysis population. There's some studies that do that have looked at that. Yeah. And then, so there's a general belief that psychologists have, or maybe other people too, that the greater amount of social support that you have, the better you can function, the better your quality of life would be, kind of the more resilient you are.
Yes.
And the way that we measure quality of life is the way we can measure social support is we can talk about the depth of your network or the breadth of your network. Okay. So how deep it goes, meaning are there a few people that you're very connected to, right, or is it broad? Are there a lot of people that you are somewhat connected to? Mm-hmm. And data from other areas indicates that either way are pretty helpful for people to maintain a more positive health and kind of mental health attitude. So, whether you're just being more connected to people, whatever that means, seems to work better. Mm-hmm. But then if we look particularly at women, and maybe even more particularly African American women, there seems to be perhaps a little bit of a different pattern, in that the depth of the network is the same. That's still pretty helpful, but the breadth of the network, sometimes when the network gets really broad, instead of it being social support, it becomes something else, which we call social strain, which is when there's more demand on you from all these different people. Oh. So the assumption was always that the more people that you're connected to, the more they give to you.
Correct.
But perhaps there is some truth to the fact that the more people that you are connected to, the more you're giving to them, and it's just more demand upon you. So we call that social strain, and it's unclear how that, how true that really is, and what types of populations or what groups of people that might be more true or less true in. But I would say, just in talking with people, there certainly does seem to be a truth to that in my experience, in that, when we talk about, I do a lot of therapy and psychotherapy with patients who are on dialysis, and very rarely are we talking about maybe the things that people would expect that you're talking about, like the challenges of dialysis. What we're often talking about is kind of regular old psychotherapy things, which is conflict with your loved one, conflict with your children, conflict with your extended network, all the kind of regular things that we psychologists deal with in psychotherapy. So to me, that might be, that does ring kind of true, that, the broader the network, sometimes the more problems you might be having, right? The more people are asking of you. So I guess we don't know yet. And, yes, when you're looking at, if you're examining your life and you're thinking about, which relationships are healthy and which relationships are unhealthy. So I don't know that having the broadest network that you can is necessarily helpful. Having people that you can count on, or there's a reciprocal relationship, you can be there for them and they can be there for you, those might be the ones that are the ones to keep around.
Yes. Well, I can certainly agree with you. The more people that I have in my life, the more pieces that I have to break off and give out. So I can certainly understand what you mean by the broad aspect of having a lot of people in your life there. What about the ethnic differences in people with kidney disease?
So, yeah, I just talked a little bit about that. I mean, I don't know that we know all that much about. I mean, as a general rule, African Americans seem to do well on dialysis as compared to other groups. There's a survival advantage, which means they tend to live longer. We don't really know why that might be. It very well might be because they're less likely to have transplants. So the healthy folks are staying on dialysis longer, so that's why they're, as a group, living longer. We're not really sure why that might be, but there are certainly, I think, just like there are ethnic differences in kind of the quality of what it is that you're dealing with. The same thing is true just because you're a patient that is dealing with kidney disease doesn't kind of make that go away. Right. And, you know, as we're moving to types of treatments that are kind of broad-based and we're trying to give people, you know, more groups of people access to care, it's also, I think, really important to kind of keep in mind the individual that you are working with and what their particular challenges, where they come from, their culture, their group.
Absolutely. I know in the African American community, it's kind of not looked upon well to receive mental health services. You're kind of looked at like you're taking the family business outside, or, you know, there are certain barriers that would keep a person from seeking out mental health help when they really need it, just because of something that's a cultural problem.
So there are a lot of barriers to care, and they're you know, they range a really broad group of different things. They can be, you know, insurance issues, it can be access issues, they can be personal kind of cultural issues. I think that part of what we need to do particularly in the dialysis community, is destigmatize the mental health experience. Sure. So like I was saying before, you know, if you're looking at the people that are just doing the very, very worst, and we say, okay, these are the people that are having a problem, so let's get them help. So then, yeah, it is kind of stigmatizing. I'm doing the worst. But if you're just looking at all the people that are not doing the best, and all of those people could use some help, so maybe it's a great majority of people could use some help, and then the stigma would go away. And I think we need to build that into the kind of standard care that we provide for dialysis patients and transplant patients.
Yeah, wow. Well, Dr. Cukor, how do people with ESRD currently go about getting care?
You know, there really isn't a great system for patients that's kind of unique for patients with renal disease. So if you're at a dialysis center, or I guess even if you're a transplant, you might have a social worker who's assigned to be working with you, which is an advantage compared to many other medical populations. But in reality, the social workers who are at the dialysis centers are so overburdened with so many things that they need to do, they're not really available to do counseling in a one-on-one kind of setup, and you know, that's not part of their job expectation, and they just are so overwhelmed with all the other things, they don't really have the space to do it. Yes. So what ends up happening is we often will refer patients out, and we'll say, go see, you know, this doctor or that therapist, and then the care burden is so high for dialysis patients. There's so many appointments. I remember I was speaking to someone and I said, you know, I think you should see somebody. I was unable to see them for a longer term. I think you should see a therapist. And the person said to me, you know, I don't even go see my cardiologist. Do you think I'm going to go see a psychologist?
Yes.
And I said, that's a good, fair point. You know, the care burden is so high. There's so many appointments, there's so many things that you're trying to do, and you know, things to keep on top of, that mental health often falls to the bottom of the list. Right. So I do think that it's challenging to get people to become motivated enough to put all that effort to go. And then sometimes when they do go, I've been hearing from patients that they don't always have very positive experiences at an intake session. So if you're a dialysis patient and the therapist that you're going to has never heard of dialysis before, they don't understand kidney disease, it's just too much to explain to kind of get that relationship to connect. So, you know, if after going through all of that you feel like you're going to have to spend 5 hours just kind of getting them up to speed, a lot of people don't have the time or the energy to do that. So there's a lot of misses, I would say, in making that connection between, therapists and patients. So it is pretty challenging within the dialysis community now to get mental health treatment.
Yeah. Well, do you foresee this ever changing?
Maybe. I think, there was a really positive step that recently happened, is that Medicare is now requiring depression screening for all dialysis patients. And I know some of the dialysis centers are not all that thrilled with an additional, they think of it as an additional paperwork burden that they have, another form that we have to get our patients to fill out.
Right.
I think of it as a profound step in the right direction. I think it is a cue from Medicare that the mental health of your patient is your responsibility, dialysis centers. So don't just farm them out or say this isn't what we do here. This is what we do, right? We're
Yes.
treating patients. So many dialysis centers now have begun administering the PHQ-2, so like this 2-question
Yes.
screen. The question then becomes, well, what happens if you indicate that you are having depression?
Yes.
So the dialysis centers have not quite figured that out yet. But I can't imagine that Medicare will allow patients to just, build up as having, yes, this patient has depression, I referred them, but they didn't go. I referred them, but I didn't go. I mean, if it's going to be 30–40% of our dialysis population is carrying a diagnosis and is being referred but not getting treatment, I think that will put pressure on the system to make some sort of fundamental change.
Right. Well, Dr. Cukor, what do you think that a patient should do? What's the first thing that they should do when they feel like they may need help?
A patient, I think, has to grow to become their own advocate, and they have to become empowered and feel like they are entitled to certain things, and just because it's not being provided to them, it doesn't mean that it's not important. They should, if they feel like they would benefit from talking to someone or medication or any kind of mental health intervention, they should advocate for it. And the first step, I think, is to go to the social worker who's been assigned to you, and if that is proving not to work out, that is just the first of many steps that people can do. So you can kind of circumvent that, and you can go out into the community and find somebody that is out there that is, empathic and interested in hearing about you and has the skills to help people move forward. Again, it is very demanding. The first step, I think, is to feel that you're entitled to that help and that there's nothing really wrong with you because you require extra help, and to be aggressive and go get it.
Right. And so we certainly wouldn't want to recommend that someone just sit around and suffer in silence.
No, we would not, we wouldn't want that. And, if you're getting the sense that even the people that you're telling are not equipped to handle what it is that you're telling them, you got to tell more people.
Definitely.
Right? You got to go find the people that are going to respond.
Yes.
There's the way that the dialysis centers are structured. It's not always about, they have a lot of limitations, let's say, in terms of what types of services that they can provide.
Yes.
So if they're not providing the service or you're not getting that service offered to you, that doesn't mean that it's not important. It doesn't mean that it's not essential. It just means they haven't been compelled to do it yet. But maybe 5 years from now they will be compelled to do it. But we shouldn't sit around and wait for that to happen. We can go out and get that help now.
Yeah, that's important news. Well, Dr. Cukor, is there a role for patients in mental health research?
That is a good question. I think the answer is certainly yes. I mean, as the more patients are involved in setting the research agenda, right, what are the questions that are important to patients, then you will have data or science that's coming back that's just more meaningful and more relevant to the questions that patients have. So I was just participating in a study which was sponsored by Cukor, and that's a federal agency, and one of their missions is to include patients as stakeholders in research and to make sure that it's patient-centric. And what we did was we compared different types of therapy or different types of treatment for depression for dialysis patients. Is it more effective to receive a drug, or is it more effective to get psychotherapy? Does it matter what your preference was beforehand? So we're still looking at that data. We don't have the answers to that yet, but those are the types of questions that I think are very meaningful to patients that in the past have been hard to get funding agencies to sponsor, but there really are very relevant kind of meaningful questions. What should, if I want help, what kind of help might be best for me?
Yeah, I understand. Well, Dr. Cukor, what do you see developing in the near future for meeting the mental health needs of people with ESRD?
I think, well, I hope that, as technology develops, the burden of dialysis will become less and less.
Yeah.
So both in terms of the time demand of how long it takes, maybe there'll be, implantable devices, there'll be wearable devices, there'll be things that you can do that don't tie you to being at the dialysis center.
Yes.
And I think also just the quality of the dialysis experience itself, as the technology has improved and continues to improve, will be less demanding on the
Yes.
person. So, the fatigue, the insomnia, all of those things, which I think are very biologically related to being dialyzed, hopefully as the technology develops, we'll have less and less of that for the people that are going through it. So I think I hope that's on the horizon. And like I was saying before, I think that, Medicare has begun to take notice, and CMS is going to, I believe, force involvement from a lot of the healthcare providers to getting more involved in the mental health treatment. And I have a sense that they might tie payments to that, so you can't have patients, kind of languishing, sitting around requiring a diagnosis. You won't get paid the same rate. And I think once they kind of put some of the muscle behind that, I think we'll see probably a renaissance, a development of particular techniques that are developed and tailored for dialysis patients. There's just not a lot of research that's out there about what's best for them and how we can do it, and what types of level of provider do you need to provide that. So there's logistical challenges. Dialysis patients are from early morning to late at night at particular sites, and they're on different days, so it's challenging to do this kind of as a network. But there's always challenges, and we'll have to figure that out as a group. But I think that the light is shining now on mental health within renal disease, and I think that positive things will be coming in the future.
Well, that certainly is good news. It's good to hear. Well, Dr. Cukor, what signs or what symptoms would a person look for to be able to tell that maybe they do need some help?
That's an excellent question. So it's really difficult to tell the difference sometimes, even for patients themselves, the difference between being tired, exhausted, maybe uninspired, and feeling depressed.
Right.
So there are things that are different. I think, one of the things that we look at very clearly is, if you're having a lot of thoughts about death or not wanting to live anymore, that's certainly a time that you should not keep those thoughts to yourself. And it doesn't necessarily mean that you're suffering a psychiatric issue at that moment.
Sure.
It could be quite reasonable, right? I mean, maybe you're suffering a lot and you want, you're not willing to do that anymore, but it certainly seems like it's time to turn to somebody and talk to them. So anytime there's any degree of suicidality, that would be a time that certainly I would recommend talking to a professional. And then above and beyond that, it is a little difficult. There's a lot of diagnostic tools that are out there that you can kind of get online and fill them out. And the way that I recommend doing it is, fill it out, and then if it looks like it's high, talk to somebody. Talk to your social worker, I think, would be the first person to talk to. The question that I often ask patients is, do you feel like you're living your life as best as you can, given the limitations that you have, right? So there are certainly physical limitations, but
That's a good question.
are you waking up inspired every morning? Are you able to do the things that really you would like to do? And if you're feeling very uninspired and just dragging through life, that's what depression feels like, I think, in dialysis patients. So I often sort of joke that I spent half my life convincing nephrologists that depression is real and it needs to be treated, and I spend the other half of my life talking to patients and telling them that depression is real and it needs to be treated.
Wow.
So sometimes it's really hard to know, even for yourself, am I depressed, or is this just kind of the usual par for the course? So I say look around the dialysis center and see if, is there somebody who is able to have a positive attitude? Is there somebody who comes in enthusiastic? So there might not be many of those people, but ask yourself, why am I not like that person? And if the reason is because of some psychological thing that's holding you back, so that is what depression looks like in dialysis patients. There's many good reasons for it, so it's very common, but I think if you're not doing all the things that you feel like you could be doing, then perhaps you're dealing with some depression.
Well, thank you so much for all of this great input, this great advice. Everyone, mental health is real in ESRD, If you are having some mental health issues or you feel like you just need to talk to someone, don't sit around and suffer in silence. It's very important to talk to your social worker, or if that's not working for you, get out and empower yourself and go out and find help for yourself. We want to thank Dr. Cukor so much for coming out and spending time with us on this afternoon. Thank you so much.
Thank you for having me.
And we look forward to working with you again in the near future.
Thank you very much. Good luck.
And we thank you so much for being with us on this afternoon. And we're going to have Aaron Battle come back, and we're going to have our Shelba come in, and she's going to give us some acknowledgments.
We want to thank you for attending and participating in our World Kidney Day live broadcast. Please comment and let us know if you enjoyed the broadcast and see if we can provide more events. I want to give special thanks to SUNY Downstate Medical Center, Dr. Sagi, Dr. Salaflu, Edleen Minton, Betty Jung, Cameraman Luke, American Kidney Fund, IPRO ESRD Network of New York, former ESRD networks. Right now I'm going to have Mr. Aaron Battle come back and talk.
Thank you again so much for participating and being involved in our live broadcast today. I want to give you some more information about what we are doing as the New York State CKD Champions. Coming up, we have our second annual Thriving, Not Just Surviving Cultural Arts Showcase, which will also be at SUNY Downstate on Sunday, May 20th of this year from 3 to 7 at the SUNY Downstate. Check our website for information regarding this. Also, we would like to ask you to join our web page, group page, if you haven't already. Most of you who are watching this today have probably already joined, and ask your other patients and other staff members to also look at and join our page. We would also like to give you some information regarding things that are happening also in the other parts of the community, the renal community. We have the Brooklyn Kidney Club, which is also here at SUNY Downstate, and for their next meeting, which will be on March the 18th from 2 to 4, they're doing a yoga and meditation exercise program. Please wear comfortable clothing. They will have a instructor. Actually, our Edleen Minton will be our instructor for the yoga and meditation exercise for the SUNY Brooklyn Kidney Club. So also, if you have any more questions or further questions regarding our group, regarding the New York State Kidney CKD Champions, you can find us on Facebook under New York State CKD Champions, or you can actually send us an email at nysckdchampions, all one word, at gmail.com, or you can call us at 917-719-1458. You can always find this information online regarding us, and also this live broadcast will be on our website, on our Facebook page after this afternoon. Thank you again so very much for joining us, and we hope to have you participate and join us once again. Thank you.